In this lecture, we will be discussing the GI system. First, we're going to talk about cirrhosis, both chronic and progressive. The first thing that happens in cirrhosis is we have inflammation and cell death. We'll have regeneration with disruption, so basically making scars and fibrosis inside the liver. And you can see in this picture, you have a healthy liver, but this is what happens when it becomes scarred and fibrotic. It will have a disorganized lobular pattern. With this scarring, we're going to have alterations in the vascular and lymphatic systems within the liver. The different ways you can get cirrhosis. So there are 4 that we're going to cover. We have linaics, alcoholic liver. So basically we have alcohol, hepatic toxic effects, and we have decreased nutritional intake. So basically the major metabolite of alcohol is aldehde, and it is directly toxic to the liver. Abuse results in broad spectrum liver disease, including fatty liver, alcoholic hepatitis, cirrhosis, and end-stage liver failure. Many alcoholics become symptomatic only when severe life-threatening liver disease is already present. Then we have post-necrotic, it's due to acute viral hepatitis or exposures to hepatotoxins. So basically we have that necrosis involving whole lobules of the liver, and we might have a collapse of the framework and it forms large scars. It may follow basically our viral or toxic necrosis, or it could even result because of dietary deficiencies. Then we have biliary, which there's a chronic biliary obstruction. So we have a progressive disease of the liver that's caused by buildup of bile within the liver. It's otherwise known as cholestasis. It results in damage to the small bile ducts that drain bile from the liver. Over time, this pressure builds up and it destroys the bile ducts, and it leads to liver cell damage. Then we have cardiac. This is because of prolonged hepatic and venous obstruction. It occurs secondary to the hepatic congestion due to cardiac dysfunction, especially the dysfunction of the right heart chambers. So cardiac cirrhosis can be caused by any right-sided pathology that can generate right heart failure that causes an increase in venous congestion and increase of pressure in the hepatic sinusoids, commonly causes cardiac abnormalities that can cause cardiac cirrhosis are valve disease, pulmonary hypertension, cor pulmonale, biventricular heart failure, pericardial diseases, cardiac tamponade, and constrictive pericarditis. So early on, we're going to have vague flu-like and weakness, maybe some weight loss and GI upset, but usually most people do not seek help until a complication develops. We may see jaundice, that's that highlighter yellow color that we've come to be familiar with. With dark skin tones, we're going to look at their palms and soles of their feet. Also the eyes, they will become very yellow in the sclera of the eye. And then our labs, most of our labs are all elevated except for protein and albumin. So our AST, this lab assesses heart and liver functions. The LDH detects tissue, the liver enzymes, and detects tissue alterations. Our bilirubin, it evaluates liver function and the condition of red blood cells. The pigment, the yellow, comes from the pigment of bile. And there is two types of bilirubin tests. There's indirect and direct. So altogether, it equals the total bilirubin. So basically, the indirect is the unconjugated form of bilirubin in the blood, and it's carried from the blood to the liver where it's conjugated into its direct form and excreted into the intestines. So when the liver is failing, of course, it's not going to do this conversion. But those two labs together make up the total bilirubin. The NH3 or ammonia will be elevated because ammonia is not converted to urea for excretion. Elevated plasma ammonia levels in hepatic cirrhosis have been attributed to lack of conversion of enteric ammonia into urea, or to its entry into the systemic circulation via portal systemic shunting, or to both. And it is always exaggerated by excessive protein intake. So we're going to direct these patients to have a low protein diet. Make sure you know what foods have high protein in them so we can limit those. The PTT will be elevated because of decreased synthesis of prothrombin, and the INR will be increased because of decreased absorption of vitamin K. Protein will be low because they're unable to process and filter, and albumin will be low because of decreased protein synthesis by the liver. Liver biopsies are performed to diagnose the cirrhosis. Before the procedure, we need to make sure we get informed consent. We're doing coagulation studies. This will be our PT-INR because these patients bleed, and we're going to get vital signs. And this is an invasive procedure, so we have to have informed consent. Intra-operatively, well, this is not a procedure that they are put to sleep for. They're basically only going to get a local anesthesia in the location of the liver. So during it, we will be taking vital signs and telling them to hold their breath. Remember where your liver is. It's kind of under your rib cage on your right side. So we have to hold our breath so we don't get other organs in the way, and the liver is exposed for us to get the sample. And then afterwards, they're going to lay on the right lateral side, and they are going to get their vital signs taken, and we're going to monitor for bleeding. Because some of the complications of cirrhosis include portal hypertension, which is persistent high portal vein pressure from obstruction or resistance. The treatment will include transjugular intrahepatic portal shunts. These shunt blood from the portal to the hepatic vein, so it helps decrease the pressure that's going on in that liver. Or they can have a portal systemic shunt. This is a last resort. It shunts blood from the portal to the superior vena cava, surpassing the entire liver, or it might go to a renal vein. So a surgical shunt, they will be staying at least 2 days. They're very painful, and they have a risk for hemorrhage. The portal systemic shunt is a last resort. There's a high mortality due to coagulation abnormalities, and there's a high risk for infection. It basically takes the portion of the portal vein flow to another systemic vein, bypassing the liver, especially the inferior vena cava or renal vein. And here's just another picture of different ways they can shunt the blood away from the liver. So ascites, this is free fluid, usually plasma, in the peritoneal cavity. This portal hypertension causes plasma to leak from the liver surface and the portal vein. A treatment includes furosemide, aldactone, spironolactone, low sodium diet. So we already have them on a low protein, but we're also going to have a low sodium diet. They might be getting a fluid restriction, so anywhere between 2,000 to 1,500 mLs per 24 hours. To remove this, we can perform, or the physician can perform paracentesis. This is a temporary relief method. Before the procedure, we need to have informed consent because it's invasive, and we need to do vital signs. During it, they are giving a local, and a needle is inserted into the peritoneum, being wary of all organs, so they will be using ultrasound. And they basically will drain up to 5 liters from the abdomen. They cannot draw more than that. We will be usually giving them albumin afterwards to help with the fluid shift and the hemodynamic change. And there is risk for infection. So we're going to do vital signs, watch for signs of infection, and watch to make sure that they are coagulated properly at the insertion site. There are peritoneovenous shunts like the Levine or Denver, and it diverts ascites fluid to the superior vena cava. And we can expect the patient then to lose weight when it's effective. They're going to have decreased girth around their abdomen, and they will have increased urine output, and they may have fluid volume excess. Then they also might have DIC. Remember, they can have severe bleeding problems, and DIC is disseminated intravascular coagulation. So basically, that's a situation where they're having clots because they don't have the correct clotting, and then they have bleeding at the same time. So it's something we have to watch for, and we're going to talk more about that when we get to shock. The alpha pump is also another one, and it will divert ascites through the bladder. So bleeding esophageal varices, blood is backing up in those esophageal vessels that are normally thin and fragile. The vessels become distended and ruptured, leading to blood loss. Treatment can include using a Sinstaken, Blakemore, or Minnesota tube. They have 3 lumens, one for gastric suction, one for the gastric balloon to anchor, and the esophageal balloon for direct pressure. The reason why we keep scissors at bedsides is we have to basically cut the inflation to the balloon so it collapses quickly, so that we can remove it if necessary. Endoscopic procedures like using sclerosing agents or bands to stop bleeding. This patient cannot have an NG tube afterwards, or it may use vasopressin therapy. Pititressin is a vasoconstrictor, and it works especially on the GI area, and so does sandostatin. But we need to watch for MI and angina in the pititressin, and with sandostatin we need to watch for nausea and vomiting, and we will give it between meals. It's actually a pill. And here is the synstatement tube. Basically, the doctor inserts it at the bedside, and they have a balloon that will actually put pressure and stop bleeding, and there is a second part that will help suck the blood out of the stomach. Too much blood in the stomach will cause our patient's ammonia level to rise when it breaks down. Our blood has got protein. They already have lots of problems with that. We don't need any more. And it can't stay any longer than 12 hours. And it's basically a temporary fix to hold pressure. This patient will probably also need endoscopy and surgical fixes. Coagulation defects are because of decreased bile salts. We have decreased absorption of fat-soluble vitamins like vitamin K and decreased factors like 2, 7, 9, and 10. So they're not going to be produced, so the patient's going to bruise easily and bleed easily. Treatment might include vitamin K injections. And then we have portal systemic encephalopathy. The patient can range from forgetfulness to a coma. It's caused by either inadequate protein degradation, so ammonia is not converted to urea for excretion, and they have an increase in circulating ammonia level, which is very toxic to our CNS tissue, or an excess of protein in the intestines from bleeding is the other cause. So if our patient had a GI bleed, they have all of this blood in their system, and our body's processing it as protein, and then we have high ammonia. So the treatment includes low protein diet and a drug called lactulose. Yes, this is a laxative, but it also helps to remove ammonia via the intestines. So we will titrate it to 4 stools per day. It's usually given 3 to 4 times a day. So you know if your patient's taking it that many times a day, they're not getting treatment for constipation. Constipation, they only get it once a day, but if they have portal systemic encephalopathy and they're getting it because they have a high ammonia level, they will be taking it 3 to 4 times a day. Patients hate taking this. There's a lot of resistance, and they don't take it at home, and they end up coming back confused and unable to care for themselves. So hepatorenal syndrome, it's untreatable. It can be a primary cause of death. So they have oliguric renal failure due to the liver failure. So basically with your portal hypertension, we have vasodilation of all of our vessels, but in our renal area we have vasoconstriction, and so there's just not enough blood flow, so that's what's actually causing the renal failure. Now this part's not on your notes, but this part we will talk about. So diverticulitis, it occurs more in the sigmoid colon from high pressure. Pain is in the left lower quadrant. They have rectal bleeding. A CAT scan is preferred diagnostic test. Acute episodes, they're going to be NPO and avoid fiber. Colon resection without colostomy is often the treatment. It is an infection of the actual pockets, which are called diverticuli, if there's more of them. So there's diverticulosis, such as pockets in the colon, and diverticulitis is the infection. So they will probably be on antibiotic, and usually one of the most common ones is Flagyl or metronidazole. And here's a picture. Sometimes they have a proctocolectomy. And in Crohn's, This is terminal ileum is the most common location for Crohn's disease to attack in the colon. They're going to have 5 to 6 soft to loose stools. Decreasing fiber is important because they have a lot of problems with the food getting stuck into crevices that are inflamed in their colon. They're also treated with corticosteroids and antibiotic, and surgery is controversial for them. Pancreatitis, so it can be acute or chronic. Acute is actually autodigestion, so basically the pancreatic duct is not functioning correctly and they are creating pancreatic enzymes that have been activated inside the pancreas. So that is what autodigestion is, and it is very painful. Their labs will show an increased lipase and amylase, and their blood glucose will probably also be very high. Our treatment is NPO, and once they are doing better, they will always be on a bland, low-fat, and caffeine-free diet. While they're in the hospital, they're treated with Phenergan and opioids and bowel rest. Remember to keep them from watching cooking shows or other people eating around them, and because that will also start the secretion of those pancreatic enzymes, and that will cause more trouble. With chronic pancreatitis, we've had cell atrophy. They will have continuous burning pain in their pancreas. You'll also see the 3 P's, which is polydipsia, polyphagia, and polyuria. So our pancreas is, of course, where we have insulin production. So they're going to have need insulin. They're going to also have need of pancreatic enzymes because that's not going to function as well anymore. And they'll be on a low-fat diet. They're also treated with opioids. And they seem to have repeated hospitalizations due to the pain and increased problems with digestion and their created diabetes. Parental nutrition. This is given subclavian or through a PICC line, and it includes proteins, carbs, fats, electrolytes, vitamins, and minerals in a single container. They can have lipids at the Y connector, or they can be added all together. I have a picture here. The white bag is one that has lipids in it. The one that's clear does not. So we always run through the filter. We're going to establish a positive nitrogen balance. This gives the gut a rest. Daily we'll be doing glucoses every 4 hours, and every morning we'll do a chem panel, and they may need a 24-hour urine nitrogen test, and we're going to do I's and O's and daily weights. We're going to wean very slowly and start very slowly because it's a high glucose containing substance. And if we stop abruptly, they'll get hypoglycemia, and we'll need to start D5 on them and to make sure they don't drop too quickly. And if we're starting it, we'll start really slowly because they could have hyperglycemia. Make sure you do your homework assignment to help you review for hepatitis A, B, and C. And here is a YouTube video that's a complete review. Colorectal cancer is the 3rd leading cause of death. It's more common as we age. The symptoms usually are a change in bowel pattern. They have rectal bleeding, unexplained anemia, anorexia, and weight loss, abdominal pain, and melena, which is bloody stools. Prevention, they will request people to do an every 10-year screen starting at 50. Make sure you're on a high-fiber diet, and you exercise, you limit alcohol, and stop smoking. All of those things will help reduce your risk for colon cancer. Treatment can be surgery and chemotherapy and radiation. Ostomies, They're either in the ileum or colon. The further down the digestive tract, the more formed the stool. Check the stoma. Pink or red is good. It should have a nice shiny appearance. A new ileostomy will have a stool usually within 24 hours, and a colostomy might take 3 to 5 days. Remember, the last thing to wake up from anesthesia is your bowels. Make sure you're applying the correct size ostomy bag and cutting the correct holes. They may need to establish a regular pattern. Some people do have irrigations because they do not have the correct peristalsis and movement of their bowels. They should have a low residue diet for the first 6 to 8 weeks. So foods like parsley and spinach are natural deodorizers. They should avoid gassy foods like cauliflower and broccoli. Avoid hard to digest foods like corn, popcorn, and celery. And mashed potatoes and rice will help thicken their stools. I have some videos that help you review different topics. The ones I showed in class was the hepatoportal system, which is the first one, and it really helps explain why cirrhosis is so damaging. Here's some muddiest points, and I will let you read those. Those are pretty easy to explain.